begrüße Sie zur 4. GMDS-Jahrestagung, 59. GMDS-Tagung in Deutschland, in Göttingen und in Deutschland. Ich freue mich, dass wir recht prominent die Veranstaltung eröffnen können, auch gleich mit sehr prominenten Rednern die Keynotes halten. Kurzer Zwischenbericht, wir sind weit über 600 angemeldete Teilnehmer für eine reine Informatik, Epidemiologie und Statistikveranstaltung, eine stolze Zahl. Ich freue mich da sehr drüber und hoffe auf ganz spannende Tage. Doch jetzt vorab wird uns begrüßen der Vorstand für Wirtschaftsführung und Administration des Universitätsklinikums, Dr. Sebastian Freitag. Herr Freitag ist in seinem Leben als Arzt geboren, als Informatiker aufgewachsen und als Wirtschaftswissenschaftler sozusagen hier in den Vorstand eingezogen. Er gehört also in den Kollegenkreis bei uns. Und Herr Freitag ist jemand, der die Höhen und Tiefen und die Vor- und Nachteile von Informatik in der Versorgungsmedizin in den verschiedenen Stationen seines Lebens innigst kennengelernt hat und mit hoher Kompetenz die Geschäftsbereich IT hier am Klinikum leitet und übersieht in seiner Rolle als Vorstand.
Heute ist die Möglichkeit einer technisch unterstützten Beobachtung von Prozessen deutlich fortgeschritten. Während früher es eher die Unvollständigkeit des Bildes war, die den wissenschaftlichen Erkenntnisdrang herausforderte, ist es heute die Vielzahl an Informationen, die verarbeitet werden muss. Schauen wir in die Bildgebung, erlaubt die multidimensionale Analyse von Vorgängen auf der Ebene des Organismus, Organebene, Zellebene, Protein- und Molekularebene. Das alles nicht nur statisch oder zeitdiskret, sondern kontinuierlich eine Fülle von zu verarbeitenden Informationen. Die Übervollständigkeit des Bildes, die vielfache Überlagerung, die extreme Auflösung ist die neue Herausforderung an die Wissenschaft. Es ist eben alles sehr komplex. Und um weiter im Bild zu bleiben, früher war man zu weit weg, um das ganze Bild scharf zu sehen. Heute steht man häufig zu dicht davor. Kompliziert hingegen wird es, wenn man bisher parallel untersuchte Welten aufeinander abbildet. Eine weitere ganz große Herausforderung. Auch hier vielleicht ein Beispiel, etwa bei der Entschlüsselung von gesetzmäßigen Verbindungen zwischen Genotyp und korrespondierenden Phänotyp. Diese sind leider nicht, wie lange erhofft, durch einer linearen Gleichung entsprechenden Algorithmus durch Determinanz verbunden, sondern durch eine weitere unabhängige Variable, nämlich der Umwelt und ihren vielfältigen Einflüssen, die zudem noch asynchron wirken, also über epigenetische Phänomene zum Teil Jahre und Jahrzehnte nach der eigentlichen Causa Einfluss nehmen. Es nimmt deshalb neben der klassischen hypothesengetriebenen Forschung zunehmend die ungerichtete, zufallsabhängige Suche nach Mustern, Auffälligkeiten in großen, kooperativ zusammengetragenen Datenbeständen an Bedeutung. Die IT wird damit nicht nur aus meiner Sicht eine technische Klammer, die ausdifferenzierte Forschungsinfrastrukturen zusammenhält, sondern sozusagen auch eine inhaltliche. Es bedarf neuer Konzepte, die lokale technische Infrastruktur strategisch so auszurichten, dass sie, ich sage es mal aus einer anderen Welt, syntaktisch und semantisch kompatible Daten liefert. Ich sprach von Konsequenzen, die noch nicht absehbar und von Antworten, die noch nicht gefunden sind. Mit Blick auf Ihr Programm steht für mich der Wille der GMDS, einen wichtigen Beitrag zu leisten, in diesem schwierigen Feld außer Frage. Die digitale Transformation, ich habe versucht, es aus meiner Sicht darzustellen, in Teilaspekten zu skizzieren, als eine der größten Herausforderungen in Deutschland im kommenden Jahrzehnt zu bezeichnen, ist deshalb sicherlich nicht übertrieben. Die deutsche Universitätsmedizin müssen hierbei auch im internationalen Wettbewerb um den Anschluss kämpfen. Daran habe ich jedenfalls keinen Zweifel. Insoweit begleiten Sie alle unsere guten Wünsche für einen erfolgreichen, erkenntnisreichen Kongress. Und diese guten Wünsche sind aus den skizzierten Gründen auch nicht ganz selbstlos. Ich danke herzlich für Ihre Aufmerksamkeit.
Es geht weiter mit Professor Paul Schmücker, dem amtierenden Präsidenten der GMDS.
1956 hat man sich mit dem Thema Data Processing beschäftigt, Lochkartensysteme. 1977 ging es um Mainframe Computing, Großrechner, Anwendungen auf Großrechnern. In diesem Jahr ist das Rahmenthema Big Data und Forschungsinfrastrukturen. Dieses Thema ist sicherlich hochaktuell, vielfältig, attraktiv und bildet im Prinzip den roten Faden innerhalb unseres sehr umfangreichen Tagungsprogrammes. Das Besondere ist hierbei ein gewisser Alleinstellungsmerkmal, die methodische Zusammenarbeit der 4 Bereiche, die ich vorhin genannt habe. Big Data, eigentlich kennen wir das schon sehr lange. Zumindest als ich 1980 einstieg in das Gesundheitswesen, haben wir uns schon mit großen Mengen beschäftigt. Aber in der Zwischenzeit nehmen diese Daten weiter hinzu. Ob das jetzt nun die Patientenversorgung ist, ob das Register sind, Kohorten sind. Und das, was ich nicht vergessen darf, ist natürlich das Wissen, die zahlreichen Forschungsergebnisse, Publikationen. Und diese Informationen, die bisher an vielen Orten entstehen, müssen zusammengeführt werden, sie müssen ausgewertet werden, sie müssen verdichtet werden und visualisiert werden. Da haben wir eine große Herausforderung. Zumindest kennen wir das schon im Bereich Archivierung, Dokumentenmanagement unter dem Stichwort Enterprise Content Management. Das waren die Anfänge, wo man versucht hat, Daten, Dokumente, Bilder, Signale, Filme etc. zusammenzuführen. Das waren die Anfänge. Das Programm, ich sagte schon, hat eine sehr tolle Breite. Ihnen allen vielen Dank und ich wünsche Ihnen eine interessante Tagung, erfolgreiche Diskussionen und schöne Abendveranstaltungen.
Wie vermessen wir den Menschen? Wie kommen wir damit zurecht, dass wir in der Bildgebung und in den molekularbiologischen Fächern eine Anzahl von Bildern und Daten gewinnen, die während einer normalen Behandlung in der Detailform, wie sie vorliegen, gar nicht mehr verarbeitet werden können? Welche Entwicklungen zeichnen sich da ab? Wie müssen wir klinische Studien organisieren? Brauchen wir ganz andere Formen von Lernverfahren, um mit solchen Daten umzugehen? Wie geht hypothesenorientierte Forschung in diesem Bereich? Und das Neueste ist dieses Heft von der Professorengewerkschaft, nenne ich das mal, dem Professorenverband, in dem das Thema in einer konservativen Organisation adressiert wird und in seiner ganzen Tiefe, die auch Herr Freitag angesprochen hat, aufgegriffen wird. Kippt das unser Weltbild? Wird die Wirklichkeit eine andere?
And if you look at activity in the clinical practice of informatics, medical records, patient record data, disease characterization, the point of this slide is that we confront what I call the chasm of semantic despair, meaning the basic science communities do not communicate effectively and translate information into the clinical practice communities. And part of that reason, it's cultural of course, but part of that reason is the underlying semantics and representation of data. There's a dissonance, there's a disconnect between the way we connect data in basic science and the way we connect data in practice of medicine. So Zach Kawane, a good friend of mine, and I published, a while ago now, a tirade talking about the importance of representing information consistently so that we can achieve the translation from basic science into practice. You'll notice during this talk that most of my friends come from the 16th, 17th, and 18th centuries, which says volumes about my social life. But you'll recognize Galileo, and these are his drawings. This is, of course, Jupiter and the moons of Jupiter. And in the 17th century, this was big data. This, of course, transformed our understanding of our place in the universe. It had impact on science, religion, society, man's appreciation. But there's not a lot of data here, even though its impact was vast. Well, you could do astronomy in the 17th century in the backyard with a telescope. But today, astronomy has become a bona fide big science. My son, who's studying astrophysics, gives me a hard time. He says I should be on data release 10 now, but that's all right. The point is, there are vast and massive databases about astronomical data. This just single database has over 1 billion objects, including 200 million galaxies, each of which is a very complex data object with vast amounts of metadata, scan information, spectral data. You get the picture. If you can't share information and contribute and leverage prior information in astronomy, you're not going to be an effective astronomer. It is a big science. It has become so over the past 30 years. Then there's physics. Not that this city would know anything about physics, of course, but nevertheless. This is a New Zealander, Rutherford, of course, who went to Manchester and conducted his gold foil experiment on a tabletop, the turn of the 20th century. Of course, that tabletop is radioactive now. It's still in Manchester, but nevertheless, he disproved what was called the plum pudding model of the atom and introduced the whole notion of quantum physics and of really the idea of a very tiny center to an atom that was not previously understood. Very small-scale science, vast implications, an introduction of a whole new paradigm of our understanding of the universe. So we've gone from astronomy of the very large to the physics of the very small. Well, how do we do physics today? Oh yes, that Higgs boson thing. And the CERN organization, a good European organization if ever there was one, 200 petabytes of data to discover the Higgs boson. Well, that's an astronomical number, 2 times 10 to the 17. A lot of money, a lot of scientists, not a lot of credit. There are only 2 Nobel Prizes out of that, but nevertheless, among 10,000 scientists. But nevertheless, the point is physics too has become a manifestly big science, dependent upon the sharing of vast amounts of information to make progress. You can't do tabletop experiments any longer in physics and make cutting-edge discoveries about the universe and the nature of reality. Well, what is it about that Higgs boson? Is it complex data? We could argue about that. You're basically measuring in a synchrotron mass, energy, and direction, not a whole lot more. What about big data as it's in healthcare? Well, we can have broad data, like national claims data, that contains vast numbers of data but is very shallow. It doesn't have much detail, administrative codes about each patient. Or we can have very deep data, like next-gen sequencing, the complete genome of patients. Arguably, terrifically deep data, but there's not a lot of it. There are probably 35, 40,000 complete human genome sequences on the planet today. There'll be 10 times more next year, but for now, there's not a lot of it. So it can be broad or deep. Well, what's the problem? Healthcare data is both. Most healthcare data, if we think about phenotyping from electronic medical records where we have laboratories and other modalities of information, including the entire omics zoo, we have social, environmental, dietary, I mean, we can go on. The complexity of information that bears on health decisions and bears on the practice of health is almost unbounded and is complex by its nature. Thus, it's harder for healthcare to enter a big science paradigm the way that physics or astronomy did, because quite frankly, their data is simpler relative to health information. So if we have complex data, the one thing I want to leave you with is the importance of comparability and consistency in that underlying data. Arguably, if the data is not comparable, you cannot inference from it by definition because it is not comparable. And if it's not consistent, then you pay an enormous efficiency price trying to put the data into a manner that you can analyze it. So that accurate and reproducible characterization, semantic consistency, which is that whole vocabulary ontology thing that I worry about throughout my career, is terribly important. And these, in turn, were ultimately validated in clinical information. So you can get data. If you throw enough data against the wall, you sometimes can get a signal, but it's very, very inefficient. Furthermore, there's this characterization of how big data is being used. Many people think that mere association is sufficient. And here's a textbook saying we have to give up the principles that we've established of knowledge and proof over the past centuries and accept that causality may not be as important as association. And that, of course, is a very insidious, a very dangerous view from a scientific paradigm. We all know that we can get spurious associations, that associations will occur that are merely by chance. And then there's the whole power issues. If we're not comparable and consistent, if we start to stratify data, let's assume, just for fun, that we have access to 9 billion patient records, every person on the earth. If we start to stratify 9 billion by age, sex, comorbidity, laboratory image, waveform, genetic profiles, and so on, even with 9 billion patients, we very quickly get into small numbers problems. That doing inferencing at the scale that we want to do inferencing in healthcare is becoming more challenging because we're going deeper and deeper into the data. And there are fewer and fewer patients within each cell, if you will, within each statistical bin. That begs the question of how well do classifications work. This has been an early paper of mine, but we updated it, we published in about 2 years ago in Health Affairs, where we compared a lot of patients, and we asked the question of whether, for example, the United States is finally introducing ICD-10. So, is ICD-10 any better than ICD-9? And the answer is, well, no. In fact, it's actually almost not quite as good. It's not statistically significant. But there's, all this fuss over going to ICD-10 is arguable compared to its clinical utility and its ability to improve practice. Well, some of you may know, in my spare time, I fuss with ICD-11 at the World Health Organization. And one of our first goals in creating ICD-11 was to establish definitions and consensus on clinical phenotype. Most of the ICDs give you a code number and then a string like myocardial infarction, and leave it as an exercise to the user to figure out what the heck a myocardial infarction is and whether or not their patient qualifies for that. We're trying to change that a little bit in ICD-11, and of course there's the other traditional use cases. The ICD, by design, is a mutually exhaustive and mutually exclusive and exhaustive classification. That's by design. So you have arbitrary hierarchies. Here's our friend, I don't know, let's say our friend is stomach cancer. So stomach cancer is allowed to be a cancer, but stomach cancer is not allowed to be a gastrointestinal disease. Can't be both. Has to be one or the other. That's the nature of a mutually exclusive classification. That's not a problem, that's a feature. That's deliberately done in a statistical classification. But it poses problems. So what we did in ICD-11 was we said, well, let's break that. Let's go ahead and make all those cross-linkages so that our friend stomach cancer is in fact a GI disease and also a cancer. Well, you'll notice it's no longer a statistical classification. We just broke it as far as being useful for vital statistics is concerned because there's a risk of counting things twice. Nevertheless, we also add a lot of information to each node, fully specified names. There's a whole data model so that there's a lot of information associated with each element in ICD-11. And furthermore, we extend it by adding more information, index terms, other kinds of terms, so that we create a semantic network for the rendering of this information. Well, you say, fine, you make this big semantic network. How are you going to use it statistically? From that, we can serialize this semantic cloud, if you will. And by the way, these are ICD-10 codes. You're not supposed to read them, but that's all right. Into a linear form so that we can create a statistical classification from an underlying semantic network. You might say, why the heck did you do that? You just turned a hard problem or an easy problem into a hard problem and then made it easy again, and why didn't you just do the first problem in the first place? And the reason is, if we make one linearization from this semantic cloud, we can make an arbitrary number of these linearizations. We can have one for morbidity, we can have one for mortality, we can have one for epidemiology, we can have one for billing, we can have one for decision support, we can have one for any use case that matters. And furthermore, we can interlink all of these meanings and representations back to the central semantic web so that we can navigate from one linearization to another algorithmically based on the underlying definitions of those representations. So that ICD-11 has multiple components, what we call the foundation component, which is really a semantic web, and what we call these linearizations that are useful for traditional public health classification, mutually exclusive representations of data. We can have it both ways in ICD-11. Now, this is relevant to the whole concept of big data, because remember I said you can't use big data unless you can make inferences from it. And to do that, you have to have consistent semantics. So this is our effort to begin to impose consistent semantics. Well, what about that SNOMED thing? What's that got to do with this? And you all know SNOMED, but they have a need to aggregate their data, and that sounds a lot like ICD. And we have a need to increase our model, and that sounds a lot like SNOMED. And what happened several years ago is that we agreed to play nicely together, and we got married. So that WHO and IHTSDO are working very, very closely. And basically, this is a mock-up of what could happen. If we weren't careful, we would make from ICD-11 a SNOMED wannabe, a bad SNOMED. And if we weren't careful, SNOMED would create a layer within it to aggregate its information that would sort of kind of be like ICD. And what we decided to do was to effectively merge our efforts. And this was our 2007 diagram, where we decided that that layer within SNOMED would be ICD by definition.
Another reason is that the predictive variables dominate the results. So when you do, we use, for example, multiple adaptive regression splines, and when you look at what this algorithm does, it eliminates many of the 700 variables, and there are a few left which have a very strong predictive power. And so therefore we can get good results. So to summarize it, and one more thing which is important, which I would like to mention, which is often not mentioned when you think about big data, but which I think is very important. When you do something like this, you need a certain cycle which resembles the cycle that Chris showed before to re-evaluate your models. Why do you need to re-evaluate your statistical models that do these predictions? Because the behavior of the human beings that create the data changes. Big data is nothing than the signature of the collective human behavior that creates the data. And when this behavior changes because of changes in legislation, because of changes in incentives for the physicians, because maybe there was a viral strong viral infection epidemic, I don't know how to say it in English, in a country, you have changes in the way the variables are related to the outcomes. And therefore what we do, we actually every weekend, we re-evaluate the regression models and test whether the regression models deviate from, whether the betas, to simplify it, whether the betas of the regression model deviate from the betas we obtained last week, and if they do so, we actually deploy new regression models into the software. Because that way, we always adapt the models to the changing reality. If you fail to do that, you would be like a spam filter who would not filter anymore because the spammers change their strategy. So you need to adapt, and like the spammers change their strategy, also patients change the way they try to extract money from the healthcare system. So this was the first example.